Good afternoon, everyone, and welcome. My name is Sophia Phillips, and I am a farmed out intern and a recent graduate from the MS Health in the Public Interest program at Georgetown University. Before we begin, I wanted to give a brief introduction to Farmed Out. We are a Georgetown University Medical Center project that aims to advance evidence-based prescribing and to educate healthcare professionals and students about pharmaceutical and medical marketing practices. We produce educational slideshows, videos, events, and information about CME courses free of industry sponsorship. We currently have fact sheets available on our website concerning Aduhelm, and we even posted one on MCI earlier today. They are free to download for healthcare providers and for the public. For access to these fact sheets or for more information, please check out our website, follow us on Twitter, and subscribe to our newsletter. I will now be followed by Naisa, who will give an overview of how the webinar will run.
Thank you, Sophia. I'm Naisa Rahman, and I am a farmed out intern and graduate from Georgetown's MS in Physiology and Biophysics program. So I'll be going over the format instructions for today's webinar. During the first half hour, Dr. Molchan and Dr. Whitehouse will each present, and this will be immediately followed by a moderated Q&A session that we expect to run about a half an hour as well. And then during the please feel free to submit any questions via the Q&A feature at the bottom of your Zoom screen. And please do not put questions in the chat as we might miss them. And without further ado, I'd like to welcome our moderator, Dr. Kenneth Keller. Dr. Keller is the chair of the Department of Pharmacology and Physiology here at Georgetown University Medical Center. His research lab focuses on neuronal nicotinic acetylcholine receptors in the brain. And Dr. Keller, thank you for being here and moderating our event.
Thank you. This will be an interesting afternoon. And I look forward to what I learn and what we all learn from our two panelists, who I'd like to introduce right now. Our first panelist is Dr. Susan Molchan. She's a psychiatrist at the Brain Injury Center at the Walter Reed National Military Medical Center in Bethesda. She is trained in nuclear medicine and did positron emission tomography research at NIH. At the Mental Health Institute, and she worked as a program director for the Biomarkers Diagnosis and Alzheimer's Disease at the National Institute of Aging. She was also a medical officer at the FDA for 5 years. Dr. Molchan has given congressional testimony on conflicts of interest and integrity in clinical research. She should be able to provide a very interesting perspective on our topic today. Our second panelist is Dr. Peter Whitehouse. Dr. Whitehouse is professor of neurology at the Case Western Reserve University, professor of medicine at the University of Toronto, and president of the Intergenerational Schools International. He is a geriatric neurologist, a cognitive scientist, an environmental ethicist, and a transdisciplinarian. And in 1986, he developed the University Alzheimer Center at Case Western. He has worked on age dementia, friendly communities, focusing on learning organizations, the continuum of long-term care, chronic disease management, and the role of integration of primary care and public health. In 1999, he and his wife, Catherine, founded the Intergenerational School, a unique public multi-age community school. He is co-author of The Myth of Alzheimer's. Sorry. He is co-author of a book called The Myth of Alzheimer's, What You Aren't Being Told About Today's Most Dreaded Diagnosis. Again, this will bring this discussion to a very high interest level for all of us, I think. So let me begin by asking Dr. Molchan to begin her presentation.
Thank you, Dr. Keller. I'll start with the basics, with what do we mean when we talk about Alzheimer's disease. And for the past 50 years or so anyway, we've been taught that Alzheimer's disease is the most common form of dementia, that it's responsible for about 60 to 80% of dementia being a global term for impairment of memory and the ability to plan and organize and make good judgment in our lives. And those things deteriorate to the point where we can't function anymore, and then we have dementia. Most people with dementia are in their 80s, age being the biggest actually the most common cause of dementia are, like with a lot of problems with aging, are a mix of things, including the pathologies that we traditionally have learned are associated with Alzheimer's disease, such as what we'll talk about a little bit later, things like abnormal protein deposits, such as amyloid, but also blood vessel changes and a mix of other things that are that we like to parcel into diagnoses that can be responsible for other dementias, such as Lewy body dementia, frontal temporal dementia, vascular or blood vessel dementia. All of these are diagnosed, but there's a lot of overlap among all of them, especially as people become older. When scientists study disease, they like to look at, well, what are the earliest features of the disease, both in the body, in this case in the brain, as well as in patients. What can we see early on? Because we want to treat disease early. So they back up, and in the case of patients with dementia, well, what can we see? In this case, in memory changes early on. So people may be at risk, either from, does it run in the family? And they did neuropsychological testing in this case, and found people with early memory changes can be found that later develop dementia. And they labeled these people with something called mild cognitive impairment. And as I think Sophia just mentioned, just posted something on their website, detailing a little bit about what mild cognitive impairment is. Now, that's been a term that's been around for I don't know, around 30 years now. That's been used as a pre-dementia, pre-Alzheimer's condition. But actually, a lot of people with mild cognitive impairment don't go on to develop dementia. I think a pretty good consensus is that about 15% go on to develop dementia a year. About 15% a year go on to develop dementia. But just because you have some changes on your memory test that show you fall into that category, doesn't mean that next year you'll still fall into that category. So people with MCI or mild cognitive impairment function just fine in their daily lives, but on their memory testing, they can pick up, you fall outside the range of normal on your memory testing. But things besides dementia or Alzheimer's disease can cause MCI, depression, drinking too much alcohol, thyroid disease. So again, it's just not what is traditionally labeled Alzheimer's disease. In the past several years, they've backed up even further. Again, answering the question, trying to answer the question, do we all have Alzheimer's disease, with something called subjective cognitive decline. Another category that some scientists are studying, which refers to self-perceived memory impairment, which is people who are concerned about getting dementia. And we're probably going to see more of those as drugs for Alzheimer's disease, or ostensibly for Alzheimer's disease, are talked up in the media. And as more people in the population get older and are at increased risk because of age, for dementia, are these people who have some self-perception of memory decline at increased risk? I think there is some mild increased risk for MCI and dementia. Here you might add something later as to what how good the data is on this. But there's some anxiety component, depression, increases your perception of having problems with memory, as well as having problems with memory, as well as having an increased risk of dementia itself. So all of these things are kind of intertwined, so it's hard to say, but again, just pushing back the bar, and again, just raising, if people have seen the Biogen, questionnaire, this is the questionnaire put out by the company for which the drug Aduhelm was approved. All of us would have MCI or Alzheimer's disease. You lose your keys or forget names. I mean, I think all of us, especially if we're over 50, do these things every once in a while. And if you look at, speaking of people getting a little bit older, sites such as on the way dementia is depicted in the media, in movies such as Still Alice, Away from Her, they depict a woman in her 50s often. Even on the Alzheimer's Association, if you look on their website, they often have a woman who looks barely 60. The one right now is a woman, not a gray hair on her head, a daughter on either side of her. And these people do not look elderly, and maybe they have early onset Alzheimer's disease. And I think this is something maybe that is something often conflated with dementias in older people. Early onset Alzheimer's disease, as I mentioned, being a rare disorder that happens in a few families that are genetically at risk. That is a different disorder from dementias in the elderly. But that is scary when we see these people who are in their 50s who develop Alzheimer's. But again, most people with dementia are in their 80s, dementia being a disease of older people. Going back to studying dementia and what happens in the brain. So a lot of things start to change with age, and including in the brain. We all develop deposits of proteins that aren't there when we're younger, including amyloid and tau and other proteins. Dr. Alzheimer noticed clumps of these in his initial patients. And as time went on, people focused on a particular one called amyloid protein. So why did they focus on this amyloid protein? There's lots of other proteins that are abnormal. There's blood vessel changes. Dr. Amyloid noticed those too. Lots of changes in the brain. As a matter of fact, and that we all have. Older people can function just fine with lots of amyloid in their brain. So why did they happen to focus on this amyloid stuff? And why this drug that was just approved is they're all excited about clearing this stuff out. And most of the drug trials have been on clearing out amyloid or stopping it from depositing. So the excitement started in the 90s with genetic studies when they found mutations in genes that code for it in these early onset disease families, early onset Alzheimer's families. They found that in 3 different genes, they found that there's mutations in this amyloid protein genes. Then they were able to engineer mice that make this gene. Then they were able to sequence it and look at how it was metabolized. Basically, they presented neat drug targets, both targets on molecularly for tests that they could develop and drugs that they could develop. So that's very exciting for diagnostic test companies and drug companies to have targets like this. That's what they need, and also for researchers to have genetics and animal studies. They developed all kinds of mice up the wazoo that they could publish thousands and thousands of papers on. They developed all kinds of different models of mice that they may have amyloid plaque depositions and other changes, even memory changes, and they were able to cure these mice. Published lots of papers, and that's what you do in academics to get ahead. Did it make a difference in terms of human care? No, it hasn't. And this has been going on for 30 years now. So this big focus on amyloid, unfortunately, has led to the relative neglect of the potential for non-drug interventions in dementia. Despite the fact that dementia incidents, there were a number of really interesting studies of dementia incidents decreasing. This coming from a number of studies, initially in the UK. I'll just mention one of the studies from the US, the Framingham Heart Study, a really interesting study that's been going on for decades in our country out of Boston, where over 3 decades that they studied, beginning in the late 70s and 80s, a cohort from them, the dementia rate decreased 44% compared to a cohort three decades later from the early 2010s. I mean, that's a huge difference. 44% decrease from the 2010s to the late 70s. If there was a drug like that, people would be putting it in the water. So why did this happen? And this similar findings were coming from the UK and other countries in Western Europe. Not all studies were consistent, but some exciting data there. It was happening in people who had at least a high school education. So they were thinking, well, there's an education component here. People are smoking less since the 70s and early 80s, better control of hypertension, cholesterol, so better heart health. But just some very interesting findings there. This led, to a focus on, well, what are the modifiable risk factors for dementia, including Alzheimer's disease? And those are detailed in Lancet Commission on Dementia Prevention, Intervention, and Care, published in 2020. They detailed 12 of them, the usual suspects. Again, the heart healthy things like hypertension, smoking, obesity, diabetes, physical inactivity, low education level, really important to get childhood education, build up brain reserve, cognitive reserve. They think that really helps later on as insults accumulate with age. Important to have a good social network, social connections, stimulation over all our lifetimes. One of the strongest associations with hearing impairment. And there's more and more data for that hearing aids, hearing aid use is protective. One study even showed decline, that memory decline slowed after hearing aid placement. I thought that was just really interesting. And there's been 3 large clinical trials. The most famous one is the FINGER trial in Finland, which actually did interventions in people at risk for dementia. These are people at risk because of their heart risk factors. What's bad for your heart is bad for your brain, basically, right? High blood pressure, cholesterol, blood sugar. So these people had all those risk factors. And after 24 months of controlling those in the study, their global cognitive functioning was quite a bit better than those in the control group. So so things just as basic as hearing aids and public health measures like controlling blood sugar, hypertension would seem to go a long way towards controlling, really making a dent in our levels of dementia as things go forward and our population ages. I'm going to stop here.
Thank you, Dr. Molchan. It's very stimulating. You bring up so many interesting points. Turn on my video. So many interesting points. We eager to hear Dr. Whitehouse's presentation, his response, and then opening it up for questions. You've given us lots of things to think about. The alternative to the amyloid hypothesis leads to alternatives to treatment, of course. Dr. Whitehouse.
Thank you, Ken, and thank you, Susan. And thank you, Farmed Out, and all the wonderful interns for creating this space for us to discuss these important issues. Glad, Susan, when first you did a great job kind of telling you where we are. And I want to come back to the aducanumab story that as a debacle, in my opinion, an approval that we should work to reverse, in fact. Mm-hmm. But by thinking that, but by going back in history to understand a little bit more about the way where we got here, to build on what Susan said. I think the important point that I think our Farmed Out colleagues do so much work on is to recognize that the pharmaceutical industry needs to make us sick or be afraid of being sick because they develop pills to treat diseases. And they make up diseases sometimes to sell the pills that they already have. And so what Susan emphasized, that if you focus rather on health, and as Ken said just a minute ago, if you focus on different ways of thinking about the ways in which we lose our health, then we think about public health, we think about education, we think about factors that we don't think about if we're seeking out the magic bullet that the companies want to offer us. And I think this one, this approval of aducanumab, is so important to pay attention to. And I thank Farmed Out for all the attention they've given it to, because the brain aging, growing numbers of older people, the challenges we face, this is a huge issue that's attracted a lot of attention. And I think we have to appreciate the issues more deeply than we have to this point so far. So let me go back in history and first mention that one of the most important parts of the history of my work with Alzheimer's disease was my collaboration with Ken on nicotinic systems and Alzheimer's disease. But before we started focusing on neurotransmitters, we had people like Dr. Alzheimer, who over 100 years ago now described originally a single case with those neuritic plaques or senile plaques or amyloid plaques that Susan has mentioned, but other features as well. It went along as a rather rare condition because Dr. Alzheimer thought it only occurred or should be labeled in people that are under the age of 65. And yet in the 1970s, Robert Butler, Bob Katzman, a number of people said, look, older people lose their memories into, why don't we lump all this together as Alzheimer's disease or senile dementia of the Alzheimer's type? And we ended up having this huge epidemic. It was sleight of hand because there are differences between those younger onset forms of Alzheimer's disease and the later forms, one of which is that older people rarely have one condition that causes the dementia. The most common cause of dementia, Susan mentioned, is actually mixed dementia with things like vascular risk factors. So that illustrates what I think is a really important point of the history and future of answering the question, will we all get Alzheimer's disease? It depends on what you mean by Alzheimer's disease, and that word has changed through history, as I just illustrated with that lumping together to create the epidemic. The epidemic continued when people made the obvious point that if you have a progressive illness, like a Alzheimer's disease, so-called Alzheimer's disease, that it starts before the symptoms become apparent enough that it causes a doctor or the family or the person to note that they've lost abilities in daily life. So Susan's already gone through that. The term mild cognitive impairment is still very controversial. It was a research term. It says the obvious, that you have symptoms or signs before in objective psychological tests before you have functional disabilities. And then this subjective cognitive decline, which I won't elaborate further other than just to say, be careful about complaining about your memory because you'll get that label. So it just means that you have to complain about your memory getting worse. And how many people do that? So A, there was the extension earlier and earlier. And B, there was a recognition that were different subtypes of Alzheimer's. So another thing about Alzheimer's is it's not a question of where we all get Alzheimer's disease. It's a question of which Alzheimer's disease will you get, because the lesson of the last 25 years is that Alzheimer's disease at many levels is not one condition. So you have to ask the question, which kind of Alzheimer's disease are you going to get? Now, this is all very confusing for patients and families, and it's even confusing for the experts. So the experts developed this ploy to redefine Alzheimer's disease once again, and to do it on the basis of biology, of what Susan called biomarkers or surrogate markers. And there you get into which ones again, but the one that got all the attention for the reasons that Susan mentioned, largely the genetics, was amyloid. And there are different ways you can measure amyloid. In fact, you're going to be hearing more and more about the biomarker measuring amyloid in the blood, in the plasma. But right now, the main marker that was used in these studies that Susan has mentioned has failed, including the one where the drug was approved, is biomarkers. But that required the doctors to say, in order to be defined as having Alzheimer's disease, you have to be measured as having some amyloid in your brain. We used to just be able to do that at autopsy, but most people don't want to get autopsied to find out that they had Alzheimer's disease when they're still alive. Brain biopsies aren't a good idea either. So we've got this rash of panels of biomarkers, and we'll feature the amyloid imaging for the remaining comments that relate to aducanumab. So why did redefining Alzheimer's disease on the basis of a biomarker, PET imaging, make so much important to the approval of aducanumab? Well, there is a long and unfortunate story here, which is still being investigated at many different levels, of the fact that Biogen and the FDA and the Alzheimer's Association, essentially, I'm going to use the word conspired, and then captured the FDA around this notion that they could approve a drug without demonstrating clinical benefit. I mean, Susan kind of alluded to this when she said the experts got so excited about publishing studies about animals. They've begun to forget human beings even more than that. So they would like to take you and do an amyloid PET scan and suggest you have an IV infusion once a month of a very expensive drug to treat a brain abnormality that may never bother you. And if that sounds weird and strange, that is what happened. Now, there are arguments about whether there's clinical benefit associated with that. But in actual fact, the latest analysis of all the studies looking at where you could find the relationship between cognition, improvement in cognition and change in amyloid came to the conclusion that this is not validated. This is a biomarker that has not stood the test of time. It is one that should not have been used to approve this drug. So what we end up having is the possibility that in actual fact, Biogen and the Alzheimer's Association could go out and suggest we all get screened for amyloid by having PET scans and then get treated based on those brain abnormalities, not whether anything is bothering us or not. And I will just wrap up that by this comment by saying that what Susan said is so important. It's the public health aspects. It's the improvement of the quality of our environment. There are now several studies that have demonstrated what you don't hear frequently from the Alzheimer's Association, which is the relative rates of dementia are going down, probably because of all the public health improvements we made in the 1970s and 80s. Improvements that unfortunately, with the climate crisis and environmental degradation and income inequity, we are essentially not learning the lessons of the past that we can make a difference in people's lives through public health. And in actual fact, I'm going to come back to this question one more time. Will we all get Alzheimer's disease? Will we all need some kind of therapy? I don't think the answer to that. I think the answer to that question is how early and how many different forms, and are we treating brain aging? Just what is this disease construct? But I do think we have a cultural dementia. And the latest book that my co-author Danny George and I wrote is called American Dementia: Brain Health in an Unhealthy Society. It's all about the public health efforts we should all be making to improve our brain's health collectively. But it also identifies the fact that the National Alzheimer's Association, the National Institute of Aging, and a supposedly small group of highly paid academic consultants have convinced us that we need to think of Alzheimer's disease in one way, the one way that's going to get them fame and fortune. There are other ways to think about it. And if we don't think about Alzheimer's disease more broadly, I will say to you, we all have an American dementia. We all are poor at remembering things about what we've learned from the past and planning for the future. So let's say we all have a dementia. We don't all have Alzheimer's disease, but recognize that it's these limitations in thinking that you're seeing in the field that are so important to challenge. Because if we don't challenge them, we're going to end up wasting a lot of money, causing a lot of harm by giving people medicines that they don't need and will not do them any good. Back to you, Ken.
Thank you, Peter. Giving us, as Susan did, many things to think about and to talk about. And we invite your questions from the people who are listening in. We have a few questions to start us off that I'd like to know the answer to myself. You've already touched on this, the relationships between plaque and Alzheimer's disease. How strong is that relationship? I think Susan alluded to the fact that we know that there are instances of people with plaque without any cognitive impairment. And we know we have animals that we can make more plaque in that don't necessarily show a memory deficit. There are so many other questions. Why is this emphasis on plaque so important to us? The question that I would raise personally is, what opportunities are we missing by focusing so much of our resources on plaques and tangles? How many other things might there be research devoted to, or money devoted to the research on, but there is no money because it's all devoted to plaques and tangles, both at the NIH level, at the ADA level, and also at the drug company level. So we have a question that person went away, okay? It was about cholesterol. So let me bring that question up again. Two things that I have in mind. One is, what is the relationship between plaques, tangles, and dementia? If there are any clear indication that there is a direct cause. And two, what hasn't been mentioned, I don't think, is the relationship of the ApoE4 gene and dementia. So let me bring that back to you, Peter and Susan, and see if we can address those if possible.
All right, Susan, you start, and I'll be happy to.
Well, the whole amyloid plaque, that was one of the frustrating things when I was at the National Institute on Aging. I left, gosh, almost 15 years ago, the emphasis on amyloid. It was really hard to get away from it, and hard for me to understand. A minority of researchers thought that amyloid was a reaction to injury to the brain. George Perry is a big proponent of that, for example, that it's basically either scarring or protective response to protect the blood vessels to whatever degeneration was going on. And if you suck out the amyloid, you're going to get more injury, as is happening actually with the Biogen drug. They're getting bleeding as one side effect. Why the emphasis on plaque? And then one big thing that I always say, there's no correlation between the amyloid, between the plaque and the cognitive impairment. So, but the researchers who studying it just became, just very powerful and published a lot and collaborated with drug companies. They became very rich. There was a lot of greed. As time went on, drug companies became more and more, academics became more involved with, and to some degree they had to, as NIH funds during different periods dried up, they had to collaborate with companies to even continue with their job. So I don't blame them entirely. And there was some interesting work to do, with companies too, but it just became just so intertwined with industry that it just became hard to get out of it. It became its own force, the whole amyloid thing. The tangle end of things, I don't know, was more interesting to me. The tau was involved prominently in frontotemporal dementia too. It was relatively neglected, but again, it's especially in aging, a multifactorial disease. In our hearts, our arteries narrow, our valves get a little floppy, our muscle doesn't pump as well. How do you treat, people don't realize that, no, we're not treating these people who are 50 years old, like the movie or the Alzheimer's Association picture says. These are people in their 80s who have lots of things going on with them. No, we're not going to give them. Some of them were suggesting giving them a cocktail of drugs, one to treat the amyloid, one to treat the tau. And, you can't give old people a cocktail of drugs. They're already on a bunch of drugs.
So our friend George Perry couldn't be on the call, but he's going to watch the recording. So he'll be appreciative of the plug. For people that think there's much more going on than just amyloid, I think the simple answer is, as you said, Susan, genes. In the early onset patients, they describe these genetic abnormalities and then overinterpreted them, Ken. Let me handle a couple of questions that you said were in the chat. The one about cholesterol. Yes, I mean, apolipoprotein E is a risk factor for late onset Alzheimer's disease if you have a particular form called the apolipoprotein E4, and it is involved in cholesterol metabolism, and as the questioner suggests, cholesterol is related to myelin and other things. But the questioner goes on to a very important point, and our friend Sam Gandy said, what the drug companies want for Alzheimer's disease is the statin that they can convince everybody to take. And you're right. I personally believe that statins are overused. We've almost put them in the water. But there's something there about cholesterol and myelin. There's also something there about the overuse of medications. The other question, which I think I suggested, Susan, that we consider, is removing the drug from the market. Now, I asked Paul Lieber, who Susan would know, I think, who I work with at the FDA, whether it is possible for the FDA to remove a drug, and it is. And Adam Kesselheim, who's was one of the FDA panel members who studies the FDA, who was essentially resigned from the committee because of this unfortunate approval. Also, he's a lawyer. He said it's possible. It's very complicated, unless something happens with safety, which it could, or the inspector general essentially finds that the relationship between Biogen and the FDA was too close, and there was some kind of unethical, illegal behavior there. So I think the fact that it is possible, even though it would be under a number of different circumstances, and it is the right thing to do, in my opinion, and others, we ought to raise the possibility, as the questioner does. Yes, we could do it. It would be hard work, but maybe it's worthwhile making the attempt. And the other thing, of course, is healthcare systems are refusing to administer it. Insurance payers are refusing to pay for it. And Biogen has actually just released some employees, has actually cut back on some of their employees because they're not making as much money out of this than they thought. So even if we don't remove it from the market, if we essentially remove the mechanisms for payment and create enough stir, then essentially Biogen will not reap the benefits of this drug that they hope they would.
Thank you, Peter. We have some interesting questions, some of which touch on what you just talked about. One
That's because
question.
I'm reading the questions, Ken. I should have.
That's good. That's
I'm
good.
cheating.
If you can read and tell us about your thoughts, that's great. I like this question from Joyce that asked, are there studies of older people who don't develop dementia or Alzheimer's, but instead remain sharp into their 80s and 90s? What characteristics do they have in common? And we can think of people that we see in the news and so forth. I don't know if they've ever been studied as a group, but I suspect that some of the things that Susan touched on about education, early education, staying in touch with your colleagues as you age, staying involved will play a role in those people who have healthy aging. And healthy aging is something we're all interested in. So are there any characteristics that you can think of other than the education and things? Are there any biological markers? I know people have looked for that for other issues related to aging, not necessarily cognitive, but other things. I don't know of any, but I'm looking for them because I use this analogy, we're all getting older, whether we like to admit it or not. And I used to be a swimmer, and I'm still looking to break 60 seconds in a 100-meter, and I haven't done it for a long time. But I know that when I do, I'm going to take some blood and find out what's different about me. We're all aging, and our muscles age, our liver ages, our lungs age. Why don't we think our brains age also? And can we slow it down? How?
Absolutely. Somebody asked here about aluminum in pots and pans, and I think aluminum hypothesis has been essentially discredited, but lead, which is coming back, is clearly a neurotoxin, clearly causes dementia, and so we need to continue to pay attention to the environment. Apolipoprotein E2 may be protective for Alzheimer's, whereas apolipoprotein E4 is a risk factor. And one of the questions relates to to other mutations that modify the risks of apolipoprotein E. Genes don't act by themselves; genes interact with each other, and so there is a lot to be learned there.
There are in that list of modifiable risk factors. I should have added, the Lancet Commission did add air pollution, and I think largely because of lead. People who live by highways, right, have a higher risk of dementia because of air pollution, and in cities, with a lot of pollution. So, but basically, I think the data. I know there are studies that, where they study healthy aging. I can't. Since I'm not in the field officially anymore, I can't name them, but from what I tell people, what I understand, it's, the Mediterranean diet, right? And exercise are the best anti-aging or best ways to preserve, right? The Mediterranean diet, or maybe the MIND diet. There was just an interesting study that I saw in, I think, the Journal of the Alzheimer's, JAD, whichever one that is, where they looked at the MIND diet. It was the study out of Rush that found that people following that, their plaques and tangles didn't change, but they didn't change the pathology over time. This was a long-term study, but they did cognitively better if they followed a modified Mediterranean diet. It's the Mediterranean diet with more nuts and berries or something, but so. The usual whole grains, lots of leafy greens. And then there are some good studies on exercise as well. I mean, things you would think, no smoking, of course, and all
that. Well said. The question that I think is interesting, because we've raised this issue, is whether CMS through Medicare will pay for the drug. Are we willing to make predictions? And for that matter, I think Medicaid, the other, of course, large federal program, has some obligations to pay for drugs, but Medicaid can negotiate the price. And I think that's the answer to both these questions. I think Medicare could severely restrict who they would pay for. That's one way they can limit things, and Medicaid might actually say to Biogen, yeah, we'll give you a nickel, and see what they say to that.
Yeah, yeah. It would be, well, it's just, well, this thing about hearing aids too, I've also added, hearing aids, even when your hearing starts to go, you should really get serious about your hearing aids, right? From what the data is looking like now. So.
Well,
So
I'm wearing mine, so
Yeah.
I think it's a
Yeah.
challenge to claim that hearing loss causes dementia.
I know, yeah. Well-
But whether it causes it or whether it worsens it or just makes it more manifest, I mean, I
Right.
absolutely agree that
Yeah.
checking people out for visual loss, for that matter, too. All
And
that
the same thing,
stimulate-
the same thing with vision, right? I mean, it makes sense, less sensory input, less stimuli to your brain, but the studies are pretty good now that it contributes to, there's more temporal lobe loss, and there are some pretty good studies.
So it may be helpful that hearing aids are going over the counter very soon.
That's
Make
that's
them
right.
more
And
available.
there's a bill in Congress where they're talking about paying for them as well. That Medicare is talking about paying for them, which would be a lot more useful than this
So we have an interesting question that I think will inform all of us is, how common is it for patients with advanced cognitive loss, and a clinical diagnosis of Alzheimer's to be found at autopsy to have few or if any amyloid deposits or plaques and tangles? I know there's something called the NUN study, but are there other studies that would dissociate the plaques and tangles from a diagnosis of Alzheimer's disease?
Yeah, absolutely. In fact, one of the points of kind of collusion and collaboration was that Biogen and FDA staff contributed to a paper in 2018 that called itself an unbiased revisiting of the criteria for Alzheimer's. And they used amyloid, tau, and neurodegeneration, and they sorted people into different categories based on whether they had one or all or none of those features. It's very clear that there are other forms of progressive dementia besides Alzheimer's disease that can cause dementia where you don't find plaques and tangles in the brain. So it works both ways. And the percentage, let me just say this, my friend Eric Larson, who does a lot of community-based neuropathology studies, will tell you, it depends on where you look, where you get the brains from. The NUN study, the very famous one that Ken mentioned, is most famous for saying that you can have amyloid in the brain and not get a dementia. And I don't know in that study how many nuns had dementia and didn't have amyloid, but I'm sure there were a few. So it's a much more complicated, and supports what I was saying before. It's a very heterogeneous set of conditions, not just one.
Let's see. One of the questions that has come up and that I have also is the cost of clinical trials is so extraordinarily high, and that to get a clinical trial going, you almost always need to have a profit motive, which brings us back to the drug companies. And then if you go to a drug company and you say you want to do a clinical trial, and they say, what's your target? You have very few things to point to that would allow them to open up their treasury to $100 million or whatever it costs to do a big clinical trial. And yet, when you go to the NIH and look for research at the basic level, one of the things that has infected all of us, I think, is they're looking for disease-modifying treatments or disease-modifying approaches. That's a very hard hill to climb, just because it takes so long for their disease to develop and then to see if there's a change. Any comments on that approach? I mean, it's almost a philosophy at NIH and perhaps ADA, I don't know, but whether or not you can get around this idea that you have to have a disease-modifying approach. In this case, of course, it means decreasing plaques and tangles, which brings us full circle back to why we're focusing on plaques and tangles.
It's a complicated question. disease modification, slowing the progression of disease, treating the fundamental aspects of the biology, however you say it, is a much more powerful message than, well, we're just going to give you a drug that's going to make your symptoms a little better. Ken, from the work with the cholinesterase inhibitors, the first generation of drugs approved, that there were claims made that those drugs would slow progression of disease. In fact, there's a meta-analysis of people on cholinesterase inhibitors who've taken them for years, suggesting that they might. But the devil is really in the details of whether you can really claim that that the design of the study suggests that it's this not more than symptomatic benefit and disease modification, which is the seduction of the biomarkers. Because if you say amyloid is the cause of Alzheimer's, I've got a biomarker and I can show you that you lower amyloid and it's related to the genetics. It's a very powerful message that says you're doing something more fundamental than just giving a symptom treating drug. But as you said, and we'll use it to make another point, the accelerated approval requires Biogen to do another study where we hope that they might do a study that would actually demonstrate clinical benefit. And the first thing the company did after they announced that they were going to charge far more than anybody thought was reasonable, $56,000 just for the drug alone, was announce they were going to take 9 years to do that study. Just think about how much money they were intending to use during that time period. I think the FDA, and Susan, who worked there, can certainly comment, has to do a better job of conditional approval, requiring studies in a reasonable period of time if they take the risk of approving the drug on the basis of a biomarker in the first place.
Peter, did they have that option at the FDA, or Susan? Do they have that option that they could give a conditional approval, say for 3 years or 2 years or whatever, and then come back and revisit that drug? As opposed to giving them a
But whether it's a conditional approval, they certainly have the right to say, you've got to do a study. And there is, they've had a bad track record at doing that because companies have dragged their feet. There are even cancer drugs that are on the market where those phase 4, as we call them, the after approval studies, failed to demonstrate a clinical benefit, and the FDA did not take it out of the market. The FDA has become captured by the industry for many reasons, not the least of which is the user fees, where the FDA is dependent on money from the industry. So we have regulatory capture. I'm going to use that word again in many ways. Yeah. Our regulatory bodies are supposed to protect us, not protect the bottom line of the drug companies.
They've lost their... They're supposed to be protecting their public health, and they've lost that that goal. They used to call the drug companies their clients when I was there. I don't know if they still do that, but this is one of the best examples of them not doing their job in protecting the public health. I mean, it's nothing less than a fraud.
Peter, you mentioned something that struck a chord with me, and that is, do we really need to cure or even change the direction of the pathology of Alzheimer's? We don't do that with most diseases. With Parkinson's disease, we treat the symptoms, we improve the life. We do that with hypertension. We treat the symptoms, we improve the life and reduce the possibility or likelihood of heart attack and stroke. And you can name other diseases, in fact, most diseases. As a pharmacologist in a medical school, I can tell you, except for antibiotics, we don't cure.
That's right. That's right.
Mm-hmm. But we do a pretty good job of decreasing the impact that those diseases might have on the person's life and even the consequences of the disease. And yet here we are dealing with people in their 7th, 8th, even 9th decade, and we think we have to cure. And I think that philosophy holds back the kind of, if you want to call them palliative treatments. I'll take it, palliative treatment, if it comes sooner than an actual cure. And I worry about that infusing the whole field of Alzheimer's research and treatment.
I think you're absolutely right. Their motto is care today, cure tomorrow.
Yeah.
As if somehow we don't need to care as we find a cure. But they never ask what a cure looks like. Ken, if you have a memory problem and you've been called Alzheimer's disease and I cure you, what does that mean? Does that mean you go back to having the brain you had before you developed symptoms, before you were 35, at age 35, age 16? I mean, nobody particularly because of what you said, this is part of an aging spectrum. If you cure an age-related disease, what do you get? A young brain? And as you pointed out, why are we surprised that brains, like all the other organs in our body, don't have a trajectory of aging? And why do we have to constantly say it's not normal aging when we have no specific way of telling aging brain and an Alzheimer's brain except for the amount of pathology? And that even that's not great. So you're absolutely right to ask that question.
It's a public relations term.
Yeah, I think.
Yeah.
I think it's a profit-making term.
And a profit, yeah, exactly. Yeah.
It's bad for, in some sense, it's bad for the public because it raises false.
They don't realize. Yeah, exactly.
It's not pushing the disease treatment.
No.
But it does open up the whole question of, can drugs be developed that will improve cognition, not just for people with a diagnosis, but for everyone? As you said, Peter, and as I alluded to before, we're all going to get older. We're all going to suffer some of the consequences, including the loss of neurons. With that, presumably goes a certain loss of cognitive abilities. But if there were a drug that could help everyone, well, would that run into the same kinds of headwinds that that other drugs like that have run into? I won't go into the details. So it's a bigger question than just maybe Alzheimer's disease. It's a question of improving cognitive abilities throughout life. My last comment is something Susan alluded to, and I think you did too, Peter. Going back to the earliest years as people develop, and you mentioned lead, there's now a second city in Michigan that has a lead problem.
I saw that.
And that scares me a lot because who are the most vulnerable are the children who are going to be living with this for years. It may not show up. They may have enough neuronal or cognitive reserve that nothing will show up until much, much later. And so some of this might be the fact that some people who grow up in a place where there's a lot of lead or something else that we don't know about, don't have the neuronal reserve that allows them to keep functioning into the 7th, 8th, 9th decade, whereas people who live in a less impactful area do.
That's very true. It's really concerning.
And actually, Cleveland has more lead than either Flint or that other city. I mean, the lead is in large cities, and it's coming out of the water. It's coming in the pipe, so it's a big issue.
Pipes, and that's part of the. Not to get political, but that's part of the Build Back scheme, is to replace the old lead pipes throughout the country. But I'm not going to get political, but that is an issue throughout the whole country. We're all subject to.
There's an interesting question that relates to this about the use of artificial intelligence and machine learning prognostic forecasting in Alzheimer's disease. And let me make a comment, if I can, about that, because there are people who think that the answer to Alzheimer's disease is big data. If we just collect enough data, we will suddenly be able to figure out all these predictive modeling. I think what we'll learn, and it goes back to what we were talking about a minute ago, is that there are as many Alzheimer's as there are people with Alzheimer's, because what your brain is at the end of life is all the things, head injuries and other things that accumulate. And the likelihood that these predictive models will allow to this kind of personalized approach, where if you have this pattern out of 1,000 patterns, you get this cocktail of drugs to individually meet your particular trajectory, I think is just unlikely. Lydia asked an important question too, that we don't want to attack all biomarkers. I mean, blood sugar has been relatively, and I'm no expert here, tied to blood pressure control, has been tied to health outcomes.
Yeah.
But I would say one thing about biomarkers, a lot of these cancer, and somebody asked the question, how much money goes into cancer and how much money goes into Alzheimer's? I think it's still cancer in the lead, but let me just say that the Alzheimer's Association is specifically trying to make us as fearful of Alzheimer's disease as cancer, so that they can get as much money as cancer. But you would think that shrinking tumor size is a good marker in cancer, right? You want your tumor to be smaller. Well, you probably do, but it's not clear that that relates to health outcomes. And the whole field of prostate cancer with markers there has shown us to be very careful. So biomarkers are important, but they sure have been overrated. And in our field, they just even haven't been established before we have first approved our first disease modifying drug. Whoa.
That's right. We have a lot to learn from cancer. The PSA test they were doing on everybody, and hopefully they've cut back on that. Mammograms in all women, they finally decided to stop doing it, well, recommending it for women under 40. Approving cancer drugs because of tumor shrinkage, even though they had no impact on quality of life or survival. I think they still do it, but they have pulled a cancer drug off the market, though it took several years. Anyway, but we're not good at public health in this country. Our lifespans are dropping. I think they're going to continue to drop. We emphasize the disease model, and there's just so much money in that. The drug companies, big food, it's just really hard to fight it.
And somebody asked a question about other countries and the likelihood of aducanumab being approved. I mean, those studies that you alluded to, Susan, show basically social democracies who have maintained their focus on public health are doing better. But my friends and the Canadian experts got together and said to the Canadian regulatory body, don't approve it. There are a number of people who are really trying to make sure that the European Medicines Evaluation Agency in Europe doesn't. I think this is it's so unfortunate, because when Susan was at the FDA, it had this huge international credibility. I'm not suggesting your departure was the only cause. The FDA has lost so much credibility in the world.
And it's such a shame. Yeah.
It's a shame, and it's also scary, because we rely very heavily on the FDA to keep us safe from potential drugs and foods. And I know their intention is good. I'm absolutely convinced of that, but they've somehow gotten a little maybe too close to the drug companies.
They have, at least their administrators, or some of them, but they have a lot of good people, but
So one bright thing that you both mentioned on the horizon, I think, is the changes in lifestyle that we've been seeing for the last 20 or plus years, that hopefully will have an impact as we go forward. And that, I'm thinking of the decreased smoking rates and perhaps the decreased cholesterol rates. I know that there are perhaps two sides to that question of statins, for example, but that may augur well for the future of vascular dementias and perhaps other kinds of dementias that are mixed in with the mixed model, as you point out. And so perhaps in 20 or 25 years, the next people sitting here talking about it will look back as a historical rather than a contemporary problem. We'll have to wait. I hope we're around to see it.
I appreciate your optimism, but I would say that we've lost life expectancy in this country. I mean, we've had the FDA mishandle the opioid epidemic. We've got COVID, obviously, and we're likely to have more. If we don't pay attention to public health, Ken, I am actually concerned that things are going to get worse, not better. I think we're losing the gains that we made in the 70s.
Peter, I agree with you about that. I'm just saying that lifestyle changes, other than COVID, other than opioid use, of course, those are affecting our
Well,
longevity.
for some of us, but the obesity, childhood obesity is rising. The diabetes rate is rising. I mean, all of that is really concerning. So that's what people are saying. You know, on one hand, yeah, there are cohorts of people that are healthier, but for the population in general, especially in the South, obesity rates and diabetes rates are rising, and so that's what those are risk factors.
You're looking for an optimistic view somewhere.
Yeah, sorry. I know.
it's
Yeah,
okay.
I know.
It's your job to keep us to keep
I
us
know.
So I'm going to give us an optimistic note. I put a plug in. So a number of my friends are here and asking questions. So Sharon Moon, who's a new friend, is with the Lown Institute, who have also been strong advocates for trying to learn the real lessons from this approval and doing a lot to improve healthcare along the lines of what we've been talking about. So the optimistic note is there are other people besides Farmed Out, and I think there's a growing attention to this. She specifically asks about childhood trauma and adverse events. And, you know, we've already talked about lead and head injuries. Lots of things can happen to kids. I think we have to take up not only a public health perspective, but a life course perspective. And there's a social scientist from Canada, which I always think is a somewhat more civilized country. I shouldn't point out the questions by name, but he asks about this subjective memory complaints. And this particular gentleman did a whole study of mild cognitive impairment and what real people thought about mild cognitive impairment. And let's just say that it wasn't as clear cut as the experts thinking that this was, you know, something that everybody would accept out of the research environment as a label that we should be using clinically. I think the subjective memory complaints, the subjective cognitive decline, it's just, isn't it obvious? I mean, how many people on this call don't think they're, you know, of a certain age, don't think their memory is as good as it used to be? The studies show that memory declines with age. Okay, so where's the threshold that you suddenly call this a disease? And, you know, it's going to get worse if we get drugs on the basis of biomarkers without even bothering to talk to us about whether we have any symptoms at all.
Certainly agree with you. You know, what you just said reminds me of a relatively newer diagnosis of pre-diabetic. You know, that used to be something that you dreaded getting diabetes, and that had a certain marker. Now people say, well, you might be pre-diabetic, and that setting us up or hopefully changing our lifestyle so that we don't become diabetic. Maybe the same sort of thing could relate to the cognitive decline that we all see. Can we do something about it? You know, whether it's doing puzzles or socializing more or something else. Well, this has been wonderful. I'm told we should wrap it up. I want to first say that I'm sorry that we couldn't get and address all of the really excellent questions that we had from our participants, from our audience. And I especially want to thank our two panelists, Dr. Molchan and Dr. Whitehouse, for leading today's very stimulating discussion about all these topics related to Alzheimer's disease. I also want to thank Adrienne Thu Berman, Director of Farmed Out, and her colleagues at Farmed Out, Patricia Benzavenka, Carolyn Renko, and the Farmed Out interns, Sophia Phillips, Nasa Raymond, and Yubita Fadik. And I want to now turn it back to Adrienne Thu Berman, who will close us out. I want to really especially thank Dr. Whitehouse and Dr. Molchan for stimulating me to think more about this, both as a participant in our world as well as a research scientist. Thank you. Adrienne, back to you.
Thank you so much. Thank you so much, Peter and Susan and Ken. That was a really stimulating conversation. And thank you everyone for coming. We have multiple resources on Aduhelm and mild cognitive impairment on the Farmed Out website and on Alzheimer's in general. So please visit our website for more resources. We certainly hope this was informative, and we hope to do some more webinars in the future. Farmed Out's mainly supported by individual contributions. So please consider donating to us, and please subscribe to our monthly newsletter, which is also very informative. Thanks again for coming. We hope to see you at a future event.
Thanks, Adrienne.
Thank you, Adrian. Thank you, Peter. Thank you, Susan.
Thank you, everybody. Bye-bye now.
Bye.
Bye.